Good morning, everyone. Thank you, Tritanjan, for inviting. Thank you, all the organizers and Dr. Ashai for inviting me and giving me this opportunity. So as we are already late, I'll just start my presentation. And so I was told that this session will be mainly targeting the students, and I have kept the presentation very basic to understand the basic concepts of radiation in limited disease small cell lung cancer. So I have nothing to disclose and no conflict of interest, and these are my acknowledgements. So we all know that 15 to 20% of lung cancer patients will be of small cell lung cancer, and it's mainly seen in aged smokers. Most of the patients will present with significant symptoms which can also include superior vena cava obstruction because of large mediastinal lymphadenopathy. It's a fatal disease, and if untreated, death usually happens within 2 to 4 years. And most of the patients will present with an extensive stage tumor, having a 2-year survival probability of only 4%. So smoking is a significant contributing factor behind this. This is the staging system. We have two different type of staging systems here, veteran affairs and the TNM. The veteran affairs are like more of a practical staging system to define treatment modalities, and they have defined it like limited disease and extensive disease. The limited disease is classically defined as a stage of the tumor or disease where you can treat it with a single radiation portal with acceptable morbidity. So this last thing is very important, that you might consider something that, okay, fine, I can include this entire thing in a single portal because I have tomotherapy machine or some other machine which can treat 40 centimeter. But the patient must be in a condition to tolerate that huge field of radiation. So with acceptable morbidity, you have to deliver the radiation. Anything beyond that is considered as extensive stage. Now, when we compare this with this current AJCC system, then stage 1 to 3 falls under limited stage disease, which is like T1 to 4 and N1 to N3 disease. And stage 4 comes under this extensive stage, which like it also can include T3 and T4 tumors with multiple nodules. So this is how we can just graphically show that this is how a limited stage disease might look like, and this is how an extensive stage disease can look like, involving both of the lungs or with distant metastasis. So workup, there are a lot of things which you must do before planning the treatment. However, I'll focus only on few things. One is FDG PET CT scan, although it is optional. But nowadays, because FDG PET has very high sensitivity of detecting nodes, so probably this might be helpful in deciding surgical resection and radiation portal, also radiation volume, and to assess the response and detecting recurrent disease. It also helps in identifying stage 1 tumors where probably surgery or SBRT has some role. And also MRI brain, because many of these patients will come with occult brain metastasis, which will change the treatment protocol. So this is how the treatment paradigm, stage 1, 2, one must evaluate for surgical resection, including a mediastinoscopy, and for very small stage 1 tumor, surgical resection, and followed by adjuvant treatment. So adjuvant chemotherapy is always part of management of small cell lung cancer, because it is believed that from the very beginning it's a systemic disease. So irrespective of stage 1, 2, 3 or 4, all these patients will require systemic therapy. Now stage 1 to 3 who are not candidate for surgery, there is a role of either concurrent chemoradiation or sequential chemoradiation. Now let us discuss few simple questions related to radiation in limited disease. The first question is radiation or surgery. So multiple studies have been done, but there is no big randomized control trial to answer this question. However, retrospective analysis have shown that in early stage lung cancer, properly staged and mediastinum evaluated, if it is a node negative tumor, surgery has better survival outcome compared to radiation. But you must evaluate mediastinum properly, either with a mediastinoscopy. Lobectomy is better. So this Cochrane meta-analysis shows that available randomized control trials do not support a role for surgical resection in the management of stage 1 to 3 small cell lung cancer. However, conclusions were of limited value due to the lack of contemporary data and the low quality of available evidence. But still, we can go by this population-based study that 50% overall survival with surgery and without RT. So, stage 1 well-evaluated mediastinum surgically fit patient, surgery should be offered. If surgery is not feasible, then SBRT has a role in such scenario. However, there is lack of data or randomized data for SBRT in those scenarios. The second question, should we go for chemotherapy or not? A concurrent chemotherapy, does it give benefit or not? So there is this meta-analysis which included almost more than 2000 patients that showed that adding concurrent chemotherapy gives almost 5.4% 3-year overall survival benefit. And the conclusion was thoracic radiation moderately improved survival in patients with limited stage small cell lung cancer who are treated with combination chemotherapy. So yes, concurrent chemotherapy is needed. Now, how should be the sequence? Should we go ahead with concurrent or sequential? So usually we give 4 cycles of cisplatin etoposide. Now whether to start with first cycle, second cycle, or can we do it after finishing the entire chemotherapy and then give radiation? So this Japanese trial, they particularly assessed this question, whether concurrent or sequential chemotherapy should be done. 231 patients, hyperfractionated 45 gray for 3 weeks and 4 cycles of chemotherapy, and the second arm was 4 cycles of cisplatin etoposide and then sequential radiation. So in concurrent chemoradiation arm, they started the radiation from day 2. And if you can see this, you see that overall survival is significantly better with concurrent chemoradiation. So the conclusion was that this study strongly suggests that cisplatin plus etoposide and concurrent chemoradiation is more effective for the treatment of limited stage small cell lung cancer than sequential radiation. However, hematological toxicity was more in the concurrent arm. The next question, early radiation or late radiation? So the definition of early radiation is radiation beginning before 9th week. That means before 3rd cycle of chemotherapy. So within 1st or 2nd cycle of chemotherapy, if the radiation is started, that is known as early radiation. Anything beyond that is late. So there is a systematic review, multiple studies, and these suggested that use of early thoracic radiation either with cycle 1 or 2 of chemotherapy was associated with improved 2-year overall survival compared with delayed or sequential chemoradiation. The benefit was more pronounced when the radiation was given with platinum-based chemotherapy. So there is no ambiguity. You should start radiation as soon as possible, either from the first cycle or second cycle. Now practically the challenge what becomes, many a times radiation planning requires time. There are some centers where the planning, the waiting time might be from 1 week to 2 weeks or even longer. And considering the aggressiveness of this type of disease, one should not wait to finish the radiation planning and start it. Rather, the dictum is you start the treatment as soon as possible. So if it is day 1 you start the chemotherapy, the moment you are ready with your radiation plan, you start the radiation if possible from day 2, or if not, then start it from second cycle. So what is about the dose and fractionation? As of now, it is an active area of investigation. I have categorically not shown any recent abstracts here because my target is just to give the basics. So as Dr. Trinanjan was discussing about some interesting trials which is being published recently. However, this is an active area of active investigation. It's a very radiosensitive tumor with a very short proliferation time. That means the tumor cells proliferate very rapidly. And these are the typical category of tumors where you have benefit of doing accelerated hyperfractionated radiation. So it's a radiosensitive tumor, so hyperfractionation has its role. And having a high proliferation rate, this gives you benefit when you accelerate the treatment and finish the treatment with a shorter time. That's how hyperfractionated radiation has more or less a standard in small cell lung cancer. And this is landmark study CONVERT, which actually compared between 2 fractions per day versus single fraction per day. The trial protocol was 45 gray standard radiation with 1.5 gray BID over 3 weeks. So you give 1.5 gray morning, evening, 5 days a week. In 3 weeks, you are delivering 45 gray. And the other arm was standard 66 gray in 33 fractions, delivering 2 gray per fraction. And all the patients received concurrent chemoradiation with cisplatin and etoposide. Now, if you look at the trial, so one more important thing was this trial was designed to prove the superiority of single dose, single radiation per day. That means 2 gray per fraction. And if you see the median overall survival, that is not statistically different in both the arms. If you see the neutropenia, it was more with hyperfractionated arm, just borderline if p-value is 0.05. Grade 3 and 4 esophagitis was same. Grade 3 for radiation pneumonitis was almost same. Because it was a superiority study and the standard arm, the trial arm or 66 gray in 33 fraction could not prove its superiority, we cannot say that this can be the new standard. So as of now, the standard remains 45 gray, 1.5 gray BID. However, because of logistic issues, most of the centers actually cannot deliver this hyperfractionated protocol in real life. So in reality, probably 2 gray per fraction daily is the standard practice. Now the next question, how much should be the radiation volume? Multiple trials have tried to understand whether the pre-chemotherapy volume or post-chemotherapy residual volume is adequate to treat. So the SWOG trial, they compared between pre-induction volume versus post-induction volume. There was no difference in local recurrence rate. The intergroup trial included the gross disease, the bilateral mediastinum and ipsilateral hilum in the treatment field, and the RTOG trial has recommended including uninvolved supraclavicular area if the tumor is located in apical region. So conclusion from all these studies and the recommendation from International Atomic Energy, they have reviewed after reviewing all the literature, and they have found little evidence to guide how to contour or delineate the target volume. But practically in 2020, there is a very good recommendation and which came from this ISTRO and ACROP group. You should actually go through this entire article. A lot of recommendation. I cannot go into each and every detail. However, the practical recommendation is to treat the residual tumor, and one must try to do a PET scan to identify mediastinal node, because PET CT has a higher sensitivity to detect mediastinal node over CT. So CT might give you a good idea about the primary tumor in the parenchyma, but it may not give you the idea regarding mediastinal node. So a residual tumor, creating ITV, if you have the facility of 4D scan and respiratory gating, so we create ITV and then create the PTV. The last question is whether prophylactic cranial irradiation should be done or not. So again, the data came from the earlier historical series where diagnostic modalities were not that much great. So this question is more elusive at this moment, where we have fantastic quality MRI which can detect even 1 millimeter brain metastasis, which probably earlier was not possible. So back then, whether the patient who were staged as stage 1 to 3 did not have brain metastasis, we cannot say. So all these trials of limited stage disease, they recommend that after achieving the PCR, one should go for PCI. And the standard dose is 25 gray in 10 fraction. There are few studies which also tried to see whether escalating the dose to 36 gray can give benefit or not, but those studies were detrimental. But you must remember that the study which gave 36 gray and the detrimental effect was actually not from CNS problem. They actually died from progressive primary disease. But there was no added benefit by giving or raising the dose. So 25 gray 10 daily fraction PCI still remains standard of care. And once you do it, you get 5.4% absolute improvement in 3-year overall survival. However, as I said, that this is an elusive area, having better quality MRI, all these patients who are undergoing MRI at the initial staging process, not showing any brain metastasis, whether PCI really improves survival or not, the current study is going on, and probably we need to wait. That study is actually assessing to whether adding PCI or omitting PCI are same or not. So we have to wait for this result. Until then, we have to maintain this as standard of care, that adding PCI after treatment completion, once the patient is achieving CR, they should go for PCI. In a very select group, like more than 70 years, very frail, probably PCI can be omitted. So this is the latest guideline from NCCN, stage 1-2, you evaluate the mediastinum, and if surgically fit, go for lobectomy, R0 resection, and they must receive systemic therapy. Always consider this as a systemic disease, and one should never try or attempt to avoid systemic chemotherapy in these patients. Node positive patients, one can consider about adding mediastinal RT, R1, R2, they should receive systemic therapy with concurrent radiation. Medically inoperable stage 1-2, we have the role of SABR followed by systemic therapy. Not feasible SABR, you go for systemic therapy along with concurrent chemoradiation. So good performance status, poor performance status, they are also important factor to guide the treatment paradigm. So good performance status patients, they should go for systemic therapy and concurrent radiation for stage 2B to stage 3C, non-metastatic disease. Poor performance status 3 to 4, start with systemic therapy, and once the performance status improve, you can consider concurrent or sequential radiation. So if it is always better to add some form of radiation if the patient's performance status improves, and for very poor performance status patients who are actually not fit for any kind of treatment, you can individualize the treatment either to best supportive care or palliative care. Thank you, and